Hello, everybody. Thanks for having me. I'm Dave Gnugnoli. As Dr. Newbar said, I've been working here at Conemaugh for almost 9 years now, working heavily with EMS. We're going to continue on with our program here. You know, the Rural Trauma Team Development course teaches this stepwise approach to the primary survey, the ABCDE method. We're going to be talking about the A and the B during this hour. These steps are tightly linked, so it's a good thing that we can keep working through them. We'll have about 30 to 40 minutes of lecture along with some videos and then some demonstrations at the end. If you have any questions, let us know and we'll go through. All right, throughout the course, we're going to be using this scenario of a patient coming into your ER that you're responding to in the field to help us guide our treatment plans, and is also demonstrate how we go about treating a trauma patient. So our case here is a 23-year-old male found by a passerby in the ditch of a gravel country road after being thrown off an ATV. He's brought to the local hospital in the back of a passersby's pickup truck at 3 p.m. on a Saturday afternoon. He arrives unconscious with noisy respirations, bleeding from his nose and mouth, multiple facial lacerations. So when we're dealing with this case, you want to start thinking about what your role is, okay? How do you think that we're going to have to start managing this patient's airway? From the ER perspective, start thinking about what equipment you may need, what type of assistance or resources you may need to mobilize. Are you going to be able to care for this patient here at your facility? From the EMS perspective, thinking about what are the simple steps you can help to maintain the airway and the breathing in this patient. Hopefully through the course of this presentation, we're going to start describing and demonstrating the teamwork and skills required for the assessment and management of airway compromise and breathing compromise. You're going to feel much more comfortable working as a team and doing some of the airway adjuncts and different things that we're going to be talking about. So here's our basic anatomy for our patient. Okay, the airway, when we're talking about it, is basically all everything from basically the nose and the mouth down to the alveoli, everything that's going to bring air in onto the patient. So you're going to have two tracks. You're going to have the nasopharynx coming down, meeting the oropharynx right down here, meeting in the posterior pharynx and the hypopharynx. It's going to go down under the epiglottis, through the vocal cords, down to the lungs, where that's going to split multiple times until it reaches the alveoli. When we're dealing with airway, we need to be aware of some certain structures here. The first being the tongue. Tongue is considerably large compared to the oral pharynx. Okay, this is a sign. This is a common cause of obstruction in patients, especially in the pediatric patients, where the tongue, the soft tissues, the palate, all of those things are much bigger as compared to the airway. So we need to be aware that simple things like positioning the patients can cause problems, and make sure that we're dealing with the tongue in those structures in an appropriate way. The other thing when we're intubating the patient is down here in the epiglottis. This usually covers the vocal cords, helps prevent aspirations or any of your oral secretions going down the airway. Now, when we're intubating, there's two different ways we typically do this. One is with the straight blade or the Miller blade, which comes in over the tongue and directly controls the epiglottis by lifting it off the vocal cords. The others with the Macintosh or curved blade, which comes down over the tongue into what's called the vallecula right here and lifts the epiglottis right off. It's really dependent on what you feel most comfortable with and to help you control the airway. So recognition of airway compromise is critical. The loss of an airway can rapidly be fatal, okay? This is especially true in pediatric patients, excuse me, where cardiac arrest is most likely the cause of a respiratory arrest. We need to make sure we're aggressively managing the airway and the patient has an intact mechanism to bring oxygen in and CO2 out. Recognizing and managing acute airway compromise are two of the most difficult tasks you have to do as a team. In order to master these things, you need to work together and make sure that everyone's working to help the patient stay stable. When we start thinking about whether we're going to intubate a patient, there's some hard things that are absolute indications for intubation. Okay, these are the reasons that we would say when this patient comes in, this patient needs a definitive airway. The first will be respiratory insufficiency. If the patient's remaining hypoxic or hypercarbic or having inadequate respirations, they're still tugging, tachypnic, having accessory muscle use despite any interventions we do, this patient likely needs an airway. If the patient's GCS is 8 or less, they're not going to be able to control their own secretions. You should intubate the patient. But not just the hard number of 8. If the patient's GCS declines from 14 to 10 during the course of your evaluation, that's a sign that this patient's having a declining of their neurostatus. And you're probably going to want to intubate that patient before you get into some trouble until they get a GCS of 6 or 5 and they're actually aspirating and vomiting on you. You want to make sure that you control the airway before you get there. If you have severe maxillofacial injuries with lacerations, swelling, edema of the oral pharynx, or neck injuries with expanding hematomas, crepitus over the areas, it's probably a good idea to go ahead and secure the airway earlier rather than waiting for the compromise to occur. Any patient that's receiving large volume resuscitation, such as crystalloids and blood, has a chance to start third spacing the fluids we're giving them. Putting an airway in is going to help you increase the positive pressure inside the chest. It's going to help you blow through some of that pulmonary edema that can develop, can help you blow through some of the pulmonary contusions or some of the other problems we'll talk about later. One key thing about inhalation injuries is you may not see the injury when the patient first comes in. It's very easy to say the patient has an inhalation injury from a fire, if there's soot in their mouth and the nose, or there's singed airways. But if the patient's been involved in, say, like a steam accident or like some other chemical irritant that they've inhaled, you may not see the airway edema initially. If there's any sort of airway inhalation issue, I would say that it's probably a good idea to intubate that patient sooner rather than later. Some relative contraindications, again, this is not like an all-inclusive list, but when a patient comes in that's fighting you, maybe they're altered from a head injury or they're on some sort of substance that's altering their mentation, you may need to intubate this patient so you can safely sedate and control the patient, both for the patient's sake and your crew. If the patient's got a cervical spine issue and they're flopping all over the bed, you can't control that patient carefully enough to help make sure there's not having any other further injury. Sedating and intubating the patient may be the best way to control the situation. We talked about in the absolute indications, if there's any issue that you think that the potential airway compromise down the road, go ahead and intubate the patient. One special note is of transport. If you're sending this patient, whether by ground, air ambulance, fixed wing aircraft, depending on where you are, the potential for the patient decompensating needs to be taken into account. It's much safer and much better to intubate that patient in your ER prior to putting them in the back of an ambulance or one of those helicopters, because that's going to make assessment much more difficult. It's going to be harder to recognize the patient deteriorating in those areas, and they're not going to have the same amount of resources and team. So if you're going to be transporting that patient or transferring that patient, try to remember to get the patient's airway secured prior to the transfer. The most common thing we sort of see with airway issues is obstruction, and this can be either from an internal source or an external source. Internal is the most common of all obstructions due to collapse of the airway, secondary to edema, direct injury, the tongue. Here in our patient, you can see this patient had a laceration through the neck. They actually had to intubate the patient distally because trying to go in through the mouth, these tissues, the trachea wouldn't line up. So they controlled the airway by going in through actually the neck. They have another tube in here, most likely a drainage tube or the gastric tube to help drain the stomach, a central line, as well as some packing here to help control hemostasis. It's important to know that some of these internal signs you may not be able to see just on your physical look, listen, and feel exam. Okay, you may have to look for other signs, like you start seeing the patient tugging or you hear stridor, some of those things that indicate there's an upper airway obstruction. The external causes of obstruction tend to be things that are like blood, foreign bodies, food impactions. You see our patient here where they have all their teeth knocked out. That's all of those are potential foreign bodies down in the airway. Patient has significant swelling around the face, tongue, and lips. This could be causing off another occlusion because there's hematoma or some sort of subcutaneous gas that's building in this area. External obstructions tend to be those that are going to be causing the airway to compress from the outside. Another thing to think about this is when you're positioning patients. When you're working with pediatric patients, they can easily obstruct their airway just simply by placing them on the bed. Children have a large occiput compared to the rest of their body. So when you place them on a flat surface, their head actually comes down like this. And so just as if there's an expanding hematoma or something compressing the airway, their airway is going to be restrained or constrained simply by positioning, putting some back rolls underneath the pediatric patients enough to lift their head back in line and get that what they call the oral pharyngeal access or your intubating access back in line. Patients with a GCS of 8 or less cannot protect their own airway. That's sort of our magic number. If you have a patient coming in and you see that the GCS is 8, you really need to start thinking about controlling it. The reason we do this is because hypoxia in a trauma patient, especially a brain injured patient, is especially problematic. Okay, when you're dealing with a traumatic brain injuries, you need to understand that there's an increased metabolic demand in the brain. The brain's trying to heal itself after these injuries, so it's going to be using more oxygen and basically using all the supplies that it has. The problem with that is the brain is a strictly aerobic metabolism. There's no way that they can convert over to any other sort of energy production. So you need to make sure that they're maintaining their oxygen saturation to make sure that those injuries are minimized in the brain. Any sort of prolonged hypercarbia or hypoxia in a brain injury patient can lead to brain damage in literally minutes. And these are not something we can come back from. Once that part of the brain dies, we can't get it back. We may be able to rehab some of these issues, but once you lose it, it's pretty much gone. Severe deficits result in minutes, as we talked about. When you're looking at an airway, you want to assess it. You want to use the look, listen, and feel technique. And this is something that we've done all through like ACLS, ATLS, all these things that you're probably fairly common from. But it's amazing how much information you can get when you just simply look at the patient. So if a patient's coming in to your facility, you look at them. Are they sitting upright? Are they talking to you, speaking in full sentences, breathing easy, no acute distress? Great. That patient's airway is probably patent. We don't need to worry about it. We can move on to the next step. But it's a fluid situation. You need to come back and revisit this because that same patient that might have been up and talking to you may have an epidural hematoma, and this is part of their lucid phase, and they're quickly going to have a decline in their GCS. Make sure that you're reassessing all of this as it goes along. Also, when you're looking, make sure that there are any signs of deformity in the airway. Is there significant trauma or lacerations to the face? Is the trachea deviated? Is there any paradoxical chest motions, evidence of a flail rib? Any malposition of the trachea that we talked about? Or is there cyanosis present? Now, cyanosis could be a misleading sign. It talks a lot about this throughout the course of the program, but this could be a very late finding. Your trauma patients could be significantly hypovolemic, significantly hypotensive, and not show any signs of cyanosis. And that's pretty much because it takes about 4 to 6 grams per deciliter of deoxygenated blood for cyanosis really to occur. If you're having a low blood volumes, you might be getting some peripheral cyanosis simply because there's no transport of oxygen in those areas. But to get the true central cyanosis, it takes a lot of blood to be deoxygenated. Listen to your patients, listen to their voice. Are they having voice changes, muffled? Is there any raspy hoarseness to their voice? Is there a stridor apparent when they're breathing, indicating an upper airway obstruction? Is there wheezing when they're talking or breathing that indicate a lower airway obstruction? Feel, okay? Dealing with trauma patients is a contact sport. You need to get in close, feel the patient, feel for crepitus, feel for any asymmetry in chest rise, feel for that trachea to make sure it's midline, feel if there's a proper air movement in and out of the nose and mouth. When the patient comes in, it's probably a good idea to go ahead and put them on oxygen, put them on a monitor. SpO2 monitoring will give you a lot of information. It'll tell you whether the patient's tachycardic. It will tell you if they're hypoxic. Getting that simple monitor on will help you immensely. If you're going to place the patient on oxygen, do it in a stepwise approach. We don't want to hyper-oxygenate these people, but we want to make sure that we maintain an SpO2 over in our 94, 96%. Start with the nasal cannula. If you're finding you need to step up your pressure or step up your oxygen content, go to a non-rebreather, go to a bag valve mask to help with ventilations. If that's not working, try to intervene in some way. First things you'd want to try is probably a jaw thruster maneuver, where you're actually pushing on the angle of the mandible and distracting the jaw forward. What that's going to do is pull the tongue off the back of the posterior pharynx, help give you a track down to the airway. Suction out any foreign bodies, blood, or anything else that is in the oral pharynx or in the nasal pharynx that you think can help you oxygenate and ventilate this patient. If those aren't working, try some simple adjuncts. The first I'd probably try is an OPA or an oral pharyngeal airway. This can be done in an obtunded patient. OPAs are basically hard plastic curved devices that go into the mouth to help pull the tongue off the posterior pharynx and provide a track of air to get through. When you're putting them in adults, you start putting them in upside down. As soon as you get it in, halfway, rotate it 180 degrees and put the bumper up to the teeth. And that's going to hold the tongue down for you. In pediatrics, you can pretty much just put it under direct observation, maybe just pull the jaw down and put the OPA in. One thing to note is that you really do need a patient without a gag reflex to use this. If you put this in someone that's awake or trying to talk to you, this is not going to go well. They're going to vomit. They're going to aspirate all over the place. This actually goes back all the way in the posterior pharynx, so it does induce the gag reflex. To get the right size, you're going to measure from the patient's tip of the mouth to the angle of the mandible, and that's going to be roughly the distance you need to have to put it in. If that's not working, or if you suspect the patient would have a problem with the OPA, you can do an NPA, which is the nasal pharyngeal airway. That's a small, like silicone or rubber tube, much softer than the OPA, that's designed to go in through the nasopharynx and all the way back to the hypopharynx. To measure that out, you do from the tip of the nose to the ear, and that would give you the distance you need for that. Nice thing about the NPA is you can actually put 2 in if you think you have an obstruction. There's bevels on each side. Just make sure you're putting the bevel up against the septum when you're putting it in. Be careful with all of these airway adjuncts. If you're finding you may need to step up and move to an intubation, make sure you're watching all of these and removing them as you do it. It is possible, and I've seen it, where the endotracheal tube can actually pull an MPA down through the nose and into the trachea. Make sure that you're managing all those prior to moving on to the next steps. And as we talked about, if you're unsuccessful, the next step is to place a definitive airway. When we're talking about a definitive airway, we're talking about placing a tracheal tube with a cuff somewhere below the vocal cords, whether it's through the endotracheal intubation or a cricothyrotomy. One of these needs to be done to secure that airway. Cervical spine injuries are not a contraindication for endotracheal intubation. It's very easy if you have enough providers to hold what we call inline stabilization. We'll see that in the video coming up of how to correctly hold the head so we're not causing any more problems. The procedure of choice probably in our trauma patients is going to be the endotracheal intubation. It's got much less risk and much less complications than when you're doing a cricothyrotomy. But know that there are some pitfalls in this. Probably rapid sequence intubation is what you would go to if the patient's at all awake. There are some situations where you can just put a tube in, but I would probably use RSI and at least give them the sedative and paralytic to help improve your chances of the intubation. Prior to doing RSI or the intubation, try to maximize the patient's pre-oxygenation. You can do that with a non-rebreather or bag valve mask, making sure that you're getting oxygen and in, CO2 out. When you're doing some of these pre-oxygenation, the other thing you're doing is what's called a nitrogen washout. You're removing those inert gases from the airway so you have a big reservoir of oxygen. To give yourself even more time, you can place the patient on a nasal cannula and turn it up to 15 liters per minute just as you start doing your intubation. That's going to give you another reservoir. It can give you anywhere from like 5 to 6 more minutes for an attempt before that patient becomes hypoxic. If your choice for RSI medications is really provider dependent, there are some relative contraindications in the setting of trauma for certain medications. Maybe when the patient comes in with a crush injury with potential for hyperkalemia, you would avoid using succinylcholine. But again, those are things you need to weigh when you're in the situation. Use the medication that you're comfortable with, what you have available, and that you're able to get at bedside. Make sure you have any adjuncts available. You make sure you have your gummoladric bougie, your rescue devices, your suction, all of this set up before intubation. The chance of success goes down markedly if you miss on the first pass. So make sure you have everything you need to make everything go as smoothly as possible. So we're going to watch a video of a trauma intubation right now. Okay. When you're watching this, think about like where your role would be, like what would you be doing in the situation? It's nice that this team actually does a good job of communicating. Just before intubation, they talk about their roles, make sure everybody is aware of what they're doing. The team leader is going to be intubating the patient. One provider is doing cricoid pressure right here. It's using what's called the Selleck's maneuver, where they're actually pressing the cricoid ring into the esophagus to help prevent regurgitation. While this is going on, you can add something called burp pressure, in which you actually distract up the airway and move it to the right so it becomes into a better view for the intubator. One provider is going to be coming up from the bottom here and maintaining C-spine control with the initial stabilization technique we talked about. And another team, and this person is going to be maintaining the oxygen. Oh yeah, yeah. Here we go.
Gonna do help with airway or do C-spine?
I'll just hold cricoid. You want me to?
Okay, I'll do C-spine.
See the patient's holding the lateral aspects of the head, trying to keep the cervical spine in line.
What size tube you guys using?
An 8-0.
Got it, thank you.
Can you hand me that?
They're going to use video laryngoscopy. If you have it in a situation, that works really well. Otherwise, DL would be the way to go. And you're going to see it's going to be working down over the tongue until you can start seeing some of the airway structures. The epiglottis is going to come into view. He's going to control it by sticking the tip of the blade into the vallecula. There it is. You can see already this patient's got copious secretions, probably blood. The airway looks edematous. It's a good idea that they went ahead and intubated this patient. The team works really well. As soon as he gets the tube through the cords, someone's going to remove the stylet. It's going to allow him to pass the tube more easily. After that, there's going to be a little bit of a dance. Everybody in the team is going to start shifting roles. The team leader is going to maintain control of that tube the entire time.
Pull the stylet out, please.
To make sure it doesn't move.
24 of the teeth.
He marks the distance to the teeth so that they can tell later if that tube is lodged or put all on them. One team member is blowing up the balloon, the other team member is getting oxygen ready, and they're getting an end-tidal device, which looks like a colorimetric device on here to make sure they can confirm placement. You can do that, end-tidal capnography if you had it, chest x-ray, auscultation both sides of the lung to make sure that you have good placement. If that doesn't go well, you may have to start using one of your rescue devices, okay? This up here on the left is what's called an LMA. This is designed to sit right over the epiglottis. This balloon blows up and just sits in the hypopharynx. The problem with these is it's not a definitive airway. It's very easy to hyperinflate the stomach if you're being really aggressive with your ventilations. If the patient does vomit, the only place this can really go is down into the trachea because this is basically going to catch it and push it back down. Luckily, this device that we're showing here does have an extra port that you can put in a gastric tube down to help decompress the stomach, which is nice, but not all of these would have it. This is also a great device if you need to bolster the patient back up. Say they start becoming hypoxic during your airway attempt, you need to bag them back up with some sort of device to help for the next attempt. This over here on the right is called a LTA or a King airway. Okay, this device is designed to be blindly inserted into the esophagus. The balloon down here blows up to occlude the esophagus. This balloon blows up in the hypopharynx and gives you a nice clean track for the ventilations to come through. Becoming familiar with these things is what's going to help you the most. Know like what your group has or what your what's in your go bag so you can be aware of how to best use these devices. If none of that works, and you need to ventilate and oxygenate the patient, the next step is going to end up being a cricothyrotomy. Two ways you can do it, either with a needle cric or a surgical cric. If the child's less than 12 years old, it's really not recommended to perform a surgical airway. You should be doing a needle cricothyrotomy, in which you put a needle through the cricothyroid membrane, attach it to a port where you can use jet insufflation or some other back valve device to help oxygenate the patient. It's not a secure airway and also does not provide much ventilation at all, but it will bridge you to possibly get that patient to definitive care. If you're going to do a surgical cric, make sure you know like what kits you have available at your facility or how you want to do it. Generally done with either just a scalpel where you do a vertical incision and then a horizontal incision down through the cricothyroid membrane, pass an endotracheal tube into the through the membrane and blow it up. That'll give you your secured airway. Some kits are provided where you can use the Seltzer technique using a needle and passing a wire straight down through into the trachea. When this uses a set of dilators and helps basically just do a much cleaner and much simpler solution than a cut down. Preparation and practice is where you're really going to come really get the most bang for your buck of this. Know what resources you have available, know where these kits are, know how to do them prior to needing them, and that'll save you in when the trauma patient comes in. Sometimes our ability to oxygenate and ventilate a patient isn't secondary to an airway problem. Okay, looking at these two patients, they have significant compromise to the breathing apparatus. This is when we're talking about breathing, we're talking about the body's ability to actively exchange gases into the lungs. Okay, we want to get oxygen in and carbon monoxide out. This is closely tied to the airway, and the reason why we always do airway first is because it doesn't really matter how the breathing mechanism is working if the air can't get in. So you got to make sure you have a direct line to get that air into the lungs. But once that's solved, we get to turn our attention to the breathing. When you're looking at these patients, this patient over here is what's called a diaphragmatic rupture. It has a gastric bubble up here. Some of the bowels actually come up through the diaphragm. It's compressed in the lungs, going to make it difficult for the lung to expand and exchange gases. This over here is looking like it could be a flail segment with ribs fractured in multiple places. There's a pulmonary contusion underneath that, which is going to impair gas exchange. And all of these things can disrupt our breathing apparatus, and we're going to talk about those as we go. So continuing with our scenario, patient came in, had multiple facial injuries, was concerned about airway. We immobilized and intubated them. We're now moving on to the breathing aspect of the primary survey. We auscultated the chest. There's absent breath sounds on the left. Vital signs show a heart rate of 130, blood pressure 70/30. This patient is still an extremist. We're not done with our work yet. We have abnormal findings in the clinical exam. We also have tachycardia and hypotension. Something's going on with this patient. So when you start thinking about the next steps, what's your role going to be here? What's on your differential? How can you help this patient go through? Did we put the endotracheal tube too far in? Did we right main stem it, and that's why we're not hearing any breath sounds on the left? Does the patient have a pneumothorax or a tension pneumothorax that's making him tachycardic and hypotensive? Does he need an emergent needle decompression? That's what this next section is going to talk about. When we talked about like what are some of the things that can impair gas exchange, well, really It's anything that's going to disrupt that mechanism. So if we have a loss of ventilation volume, anything that's going to be a space occupying lesion in the chest, a pneumothorax, a hemothorax, diaphragm rupture is not going to let those lungs expand. If we have an impairment of circulation, if we just don't have enough volume, we've lost tons of blood onto the ground at the initial site, patient's hypovolemic, we're not getting enough red cells into the circulation that's going to come over the lung and pick up that new oxygen, that can lead to breathing problems. If we're having a pulmonary contusion, where you have capillary leak in the area of this injury, it's going to cause some congestion. Blood's not going to be able to get through there as easy. There's going to be edema, blood leaking out of the capillaries, so we're going to lose blood as well, have problems ventilating in that area. If we lose muscle control, if the patient has a neurologic injury that's making it so they lost the respiratory drive, or if they have some sort of paralysis that's causing their intercostals to no longer cause the ribs to expand or the diaphragm to move, that can lead to an impairment of gas exchange. Or if you have a flail chest, when you have a flail chest, that part of the chest is actually not working with the rest of the rib cage, and it's not going to help you expand the lungs. Again, we're going to do look, listen, and feel method. Look at the patient. Say, do you see any flail chest motion? Is there asymmetrical chest rise? When you look at the head, are there any new problems that you can see with the airway? Inspect the neck and soft tissues and make sure there's no crepitus or expanding hematomas. Is there any JVD, or are there flat? Is there a flat jugular venous system? Listen to the patient. Are there absent breath sounds on one side? Are there abnormal breath sounds, rales, rhonchi? Do you notice any flail segments or any chest wall instability or subcutaneous emphysema when you're palpating the patient? There are 4 things you really want to find on this primary survey. It's tension pneumothorax, severe flail chest, massive hemothorax, and open pneumothorax. These are things that are going to require emergent correction, and these are the things you can't miss when you're going through this primary survey. When we talk about a tension pneumothorax, what's happened here is the lung's been injured. Something's either penetrated it or it's bruised, and they're like, say, a bleb is ruptured, and it's causing air to escape outside the lung. When that happens, air can fill in between the lung lining, the pleura, and the lung space, and there's no way for it to get back out. So every time we breathe, the pressure increases, and compresses down these lungs. What happens is then it starts, the only way it can continue to expand is either go out through the skin, as you see here in subcutaneous gas, or over the midline and start pushing this mediastinum over. This is going to be a clinical diagnosis. This is one of those x-rays you probably never want to get. This patient needed a needle decompression 10 minutes before this picture was taken. When you're looking clinically to help you diagnose it, you want to look for distended neck veins. The venous system's not going to be able to bring blood back into the SVC because there's so much pressure in here, it's congesting everything. They're going to have unilateral breath sounds with no breath sounds on this side and probably coarse breath sounds over here. There's going to be tracheal deviation away from the site of the injury because the whole mediastinum is shifting. You're going to have hyperresonance. When you tap on this, you're not going to hear that sort of dull lung percussion. It's going to be a hollow sound. And then we talked before about cyanosis, and late in the course, you might see some cyanosis just because this patient's not ventilating very well. What this patient needs is emergent decompression with a needle, a needle thoracostomy. Basically, you're going to go in around the midclavicular line in the second rib space, put a large bore needle in that area, and help suck out some of that air. If you do it right, you'll feel a large rush, and the patient's hemodynamics will improve. After that, you're probably going to have to put a large bore chest tube in. This is only a temporizing measure. When the lung re-expands, it can easily kink whatever angiocath you've put in there, and it'll start the whole process again. So placing in a large bore chest tube after this help make sure that there's no other problems. A flail segment is when you have 2 ribs fractured in 2 or more places. When you're looking at this video, you can see that this part I'm circling is moving basically in opposition to the rest of the chest. When you're breathing, you're actually causing negative pressure by the expansion of the diaphragm and the rib cage to draw air in. And when this part or this island of ribs or this section of ribs is no longer connected to anything else, you're going to have it being sucked in during inhalation. It's going to cause decreased ability for the lungs to expand. It also takes a large amount of force to be created. So underneath it, you're going to end up with a pulmonary contusion, which you talked about before, which causes decreased gas exchange secondary to the edema, the blood in the area. The way to treat this is you're really going to have to make sure that you aggressively manage this patient's ventilations. It's probably a good idea, especially if there's a long transport, to make sure this patient's intubated so you can provide positive pressure and sort of work and stabilize this chest. We don't really do any chest binding anymore. That impairs wall motion everywhere. Any restriction to the chest is not a good idea in this a trauma patient. The treatment is basically just make sure you get adequate ventilation and supplemental oxygenation. Pain control can help out a lot in this situation to make sure the patient's breathing easier. Massive hemothorax can be pretty impressive. This leads to a mechanical disruption of the breathing mechanism because all of this blood is filling this chest side and making sure the lung can't expand. They can get a significant amount of blood loss into this area, oftentimes over 1,500 cc's. This is sort of the classic finding you see on like a supine film where this entire lung field is whited out. This is because when they're laying down, the blood is layering here, and it's not going to let you see much of the lung fields. When you're clinically looking for this, you're going to see flat neck veins instead of the JVD you saw with the pneumothorax. This is because the patient's actually lost all their volume into their chest. You're going to have unilateral absent breath sounds, dullness to percussion, and cyanosis again. The treatment for this is really going to be simultaneous administration of blood products as well as a large bore chest tube. You need to make sure that we evacuate this blood so that the lung can re-expand and we can adequately ventilate our patient, but we also need to be replacing the blood we're probably going to lose. This patient's going to need surgical correction, needs to get to a definitive care as soon as possible. And this is probably the likely cause right there. This patient looks like a bullet fragment stuck in the left lung. An open pneumothorax or a sucking chest wound also impairs ventilation. What happens with a penetrating trauma here is that there's some sort of injury that goes in and accesses the chest wall, goes through and into the pleural space. When this happens, every time the patient breathes in, this allows access of air to come in through this port. As they breathe out, the lung goes up against the wound and it causes basically a flutter valve so the air can't escape. So we're slowly building up air every time we inhale. The treatment for this is going to end up being an occlusive dressing. And when we use an occlusive dressing, we're going to tape it on 3 sides. So if I have a square here, I'm going to place over the occlusive dressing, tape it here, here, and here, leaving this open so not only blood can drain, but also air. That's the way when the patient sucks in, that occlusive dressing is going to be covering over the hole. When they breathe out, it's going to allow the air to escape. This patient's also probably going to need a chest tube. We're not going to put it right through the hole. We're going to go over where we normally do in the mid-axillary line. If your injury's over here, try to just avoid going through the same track. It's a bad idea to end up going through the same area. The interventions we can do to help the breathing, we talked a little, just like we talked about with the OPAs and the MPAs. In the airway section is one, we're going to start putting this patient on oxygen. Make sure they're monitoring again, make sure our SpO2 monitors are okay. If you see signs of that tension pneumothorax, JVD, hypotension, trachea distraction, make sure that you needle decompress this chest. It's not a good idea to wait till you get a chest tube set up or wait till you have other definitive, just needle that chest because these patients can decompensate quickly and enter cardiac arrest. After the needle decompression, or if there's a hemothorax or a sucking chest wound, make sure we can put the chest tube in. And we're going to see a video on that in a couple minutes. Now, the technique for this varies, but in general, you're going to look for what's the 4th or 5th intercostal space lining up with the nipple in a male or the inframammillary crease in a female in the anterior mid-axillary line. Make a cut down into the subcutaneous tissues. Bring a hemostat up and puncture through the pleura, open it up, sweep the area to make sure there's no adhesions, and put your chest tube in. And Dr. Dumar does a great job showing this in our video in a much more detailed manner. Finally, if the patient still, despite all of this, you still can't improve the patient's breathing mechanism, the patient should be intubated. Some things that you're going to find on exam aren't going to show up on your primary survey. These are going to be found later either by radiology or as they expand and cause problems. These are like simple pneumothorax, simple hemothorax, rib fractures, pulmonary contusions, ruptured diaphragm. Some of these things may be hidden, but we need to keep looking for these. If we see some of these things and it's not actively causing a problem in the patient, make a note of it, tell the receiving team because they need to know that these things may cause problems down the road. When we're looking here, you have a simple pneumothorax where I don't see any rib fractures, but you can see this lung line right here. And then there's no lung markings past here. This is where you have a pneumothorax. This is often something that may be even asymptomatic to the patient because they have so much else going on. So what equipment do you need to adequately care for a patient? Like how do you prepare yourself for a patient to come in and deal with the airway and breathing? Well, the first thing you got to do, like Dr. Dumar said, is practice. You have to be ready for something like this to come in. You have to have your equipment ready to make sure you can respond. But with that, it doesn't take a ton of equipment. Make sure you have a stethoscope so you can auscultate your patient. Make sure you have a needle and syringe if you need to do a needle crike, needle decompression, but also if you need to help pull blood or anything else like that. Bag valve mask can help you ventilate a patient prior to getting a secure airway. Chest tube and supplies, medications. Probably at least you're going to want to have your RSI meds, some sort of sedation. like etomidate, some sort of paralytic such as succinylcholine. You're going to want to have pain meds, anesthesia, lidocaine or bupivacaine if you're doing procedures on an awake patient, and all of your intubating equipment, such as your tubes, your stylets, and everything like that. Some of the pitfalls you can have when you're coming up on this is that some of our own interventions can lead to further problems. Gastric distension is common if you're aggressively ventilating a patient. If you're bagging somebody because they're not breathing, they need to be ventilated and oxygenated, it's very easy to insufflate the stomach. This can lead to vomiting, this can lead to regurgitation, which then lead to an aspiration event. Equipment can fail. It's probably a law that if you're dealing with a troubled patient or someone that's really sick, something is going to go wrong in the equipment, whether it be a monitor, whether it be the ventilator. Have a backup plan so you can address these. Make sure you have a portable monitor or something along those lines you can switch over to. Make sure that you have someone that can safely bag the patient if need be. Some things just get worse. We talked about those things we find on like the secondary survey, the simple pneumothorax, the simple hemothorax. Those can progress to a tension pneumothorax, especially depending on how we transport the patient. If we're sending a patient via air ambulance with a simple pneumothorax, that is a high probability that's going to turn into a tension pneumothorax just because the pressures are going to change and that's going to expand in the chest. Tubes will dislodge. Make sure when you're rolling the patient or transferring over to a new litter that we're maintaining control of all these, because it's very easy to pull on any central lines or endotracheal tubes. And it's difficult to assess these patients in a normal, noisy environment. The environment around a trauma patient, it's excited, it's noisy. But do your best to keep like a level head, keep your team together. It doesn't really matter which team member you are, make sure that you're talking and communicating well and showing respect to your other teammates. All right, so we have some questions.
If you would just run through them.
Yep. Yeah. All right. So our first one. So absolute indications for intubation include all of the following except A, a T3 spinal cord injury, B, Glasgow Coma scale of 8 or less, C, severe maxillofacial injury, and D, neck injury with soft tissue swelling and airway compromise. I'll let you guys pick. It looks like where we are, it is A, the T3 spinal cord injury. All of these other were in the absolute indications for intubation. All right. I click it. All right. There we go. Okay, all of the following injuries must be identified and immediately addressed during the primary survey except a simple pneumothorax, a massive hemothorax, a tension pneumothorax, or an open pneumothorax. We talked about those 4 things we wanted to find on our exam, and one of these is not. Yep, so looks like we're getting like a consensus. It is the simple pneumothorax. If it's a tension pneumothorax, that's when you would decompress the chest immediately during your primary survey. The simple pneumothorax you tend to find on like when you're starting to do the accessory imaging that you may do during the secondary survey. All right. All right, next question. An 85-year-old female is transferred by ambulance to a 25-bed critical access hospital with no surgical capability. The patient was found by a neighbor near the mailbox after she reportedly fell on a patch of ice. The exact time the patient was down on the ground is unknown. She is unresponsive to verbal and painful stimuli. Her heart rate's 50, blood pressure 170/80. She has respirations of 16. The nearest trauma center with neurosurgical capabilities is an hour away by fixed wing aircraft. Prior to transfer, how should the airway be managed? A, does not need any airway intervention. B, endotracheal intubation. C, cricothyrotomy. D, supplemental oxygen using nasal cannula. And it looks like we have consensus again. Yeah, I would say B, endotracheal intubation. This is one of those cases where you're going to be transferring the patient over a long distance. They're in the back of an aircraft. You may not be able to sense that they're decompensating. So I'd probably make sure you have a secure airway prior to transferring this patient. All right, rapid sequence intubation should be should be done only after the cervical spine is cleared of injury. B, uses the long-acting paralytic such as pancuronium so that many attempts are possible. C is used to help assist with planned placement of resource rescue device. D should be done following initial airway management with a bag valve mask to allow pre-oxygenation. Yeah, so it looks like we have consensus coming. D is what I would pick. It should be done following initial airway management with bag valve mask to allow pre-oxygenation. The other top answer was C, to help assist with planned placement of rescue airway device. I would not paralyze the patient unless I have the ability or plans to intubate them. So make sure that, like, if you're putting in an LMA, an OPA, NPA, that's not a reason to paralyze the patient. Make sure that you're only doing this if you're going to intubate. Once you paralyze them, it's pretty much game over. You have to have a definitive airway because they're not going to breathe with you, depending on which medication you choose, for, up to 45 minutes. Okay. Tension pneumothorax may rapidly become fatal. Clinical signs and symptoms include all of the following except A, muffled heart tones, B, respiratory distress, C, distended neck veins, and D, unilateral absence of breath sounds. I wasn't waiting long enough before I realized I gave you the percentage. I didn't realize I gave you the percentage. All right, so we're starting to get a clear winner here with A, muffled heart tones. That's true. With the tension pneumothorax, you're probably going to see the patient in respiratory distress. They do get the distended neck veins because the venous return is obstructed because the entire mediastinum is moved over to the side and squeezed. And they will probably have unilateral breath sounds. Sometimes you can get transmitted breath sounds to the other side, but for our purposes, it's not going to be anywhere near the other side. So they should have unilateral breath sounds. All right, so that's the end of our section. Remember, be prepared, have necessary equipment, recognize an airway or breathing problem early and act early, fix that, and then anticipate the pitfalls. We're going to watch some videos, but does anybody have any questions before?
It looks to me that he's got a lot of blood in his airway. His face is really unstable. GCS is less than 8. I'm sure I'm going to have to intubate this guy, but it's going to be difficult. Jody, can you give me the difficult intubation kit? And Pam, this guy's most likely going to have to go to the trauma center. Can you get on the phone and tell him we're probably going to have to transfer and see what kind of modes of transportation are available to him?
Yes, I'll do that right now. I'm on
Okay.
Florida Medical Center.
Kim, if you'll go ahead and get the monitors on, if at all possible, and when you're done, see if you can get me an IV site. Jody, thank you, getting the close cut off. And if you can you bring me over the CMAC while I'm bagging them here?
Yep.
It's sort of hard to bag right now. Do we have a name on him? No name? Unknown? Okay. All right, it doesn't seem to be responding to me at all right now. Let's take a quick look here. Let me know when it's up and running.
We are tachycardic in the 130, so
And do we have a pressure on him yet?
I'm getting that right now. Respiratory's here.
Respiratory. I'm going to be taking a look here for the intubation. When I'm done, I may need you to bag for me, okay? So I'm going to,
Ready to go?
saturations are low, he's hypotensive. And really can't see much in there at all right now.
Start with blood pressure.
Can you bring that up for me, Jody, so I can see? Yeah, lots of blood in there, but I think I can see pretty well. Can you give me a bougie, please?
Sorry, sir.
Alright, I can feel the tracheal rings. How about a 7.5 endotracheal tube? Kim, can you pass that over to the bougie for me? Can I grab hold of the bougie for me? Pass this tube in. Looks like it's going through the cords. Okay. Now, could you please pull the bougie out for me, blow the balloon up, and alrighty. Please assess if I've got breath sounds or not. His really difficult to bag.
No breath sounds on the right, sir.
Can you take the balloon down for me? I'm going to pull this tube back about 2 centimeters. I'm actually at 22 centimeters. I don't think I'm too far in. Okay. Balloon up again. Reassess. Jody, can you do vitals again for me?
Heart rate of 131. Sat 73%.
Okay.
BP is 70/30.
All right, Alicia, can you take over the bagging for me here,
No
please?
breath sounds on the right, sir.
Okay. Can I have a second? So the right chest is not moving, the left chest is moving. He's really hyperresonant. I think he's got intention pneumothorax on the right. Jody, can you give me the angiogram? I'm going to go ahead and decompress him because he's hypotensive and hypoxic. I'm going to use this second intercostal space anteriorly mid-quadricular line. Tom, that's not going in. Actually, there we go. There we go. And I do have a rush of air with that. Thank you. And how's he? Is he bagging a little bit easier now? Saturation?
Waiting for a sat.
All right. Jody, if you'll go ahead and give me the chest tube setup, because I know I'm going to have to put a chest tube in. At this point, we're going to insert a chest tube. The needle's already in the chest. That's a temporary measure to get rid of the pneumothorax. But the definitive treatment is to put a tube into the chest, a tube thoracostomy, or a chest tube insertion. Typically, for trauma like this, we'll use a larger chest tube, a 32 or 36. I know the literature says small chest tubes drain just as well, so anything from a 28 above will work. However, the larger the better, and I'm going to make this hole big enough to put my finger in anyway, so I might as well fill that hole with the tube to drain the blood that's in the chest. So at this point, we're going to go ahead and insert the chest tube. The injury is on the right side. The pneumothorax and the hemothorax are on the right side. So typically for placement of the tube, I want to go between the mid-axillary and the anterior axillary lines, just anterior to the mid-axillary line. That's just for comfort and placement, and typically I'd like to go above the 5th or 4th rib, or the 4th interspace, or the 5th interspace. And on the male, if you take the infraareolar border and come straight across, that should put you in about the 5th intercostal space. On a female, if you lift up the breast, the inframammary crease, follow that down, should take you to the 5th intercostal space. So at this point, I'm going to prep the patient with betadine. I'm not going to do it on the mannequin because it will destroy the skin. But prep the field, drape it if you have time. If the patient's unconscious, obviously I'm not going to use lidocaine now. This is an emergency, but if you were awake, I would anesthetize this with lidocaine or marcaine for comfort, of course. But at this point, just anterior to the mid-axillary line, 5th intercostal space, I'm going to make a skin incision. And the incision's right. I'm going to make the skin incision down to the skin subcutaneous tissue. Now typically I'll cut down right on the rib, of the 5th rib, because I don't want to cut through and accidentally cut the lung, because everyone's sort of excited in these situations. I'm going to take the hemostatin spread into the subcutaneous tissue, come up and over the top of the rib to avoid the neurovascular bundle that goes underneath the ribs, pop into the pleural space. You'll feel the pop, and that's typically the most painful part for the patient if they're awake. And then I'm going to spread this so that I can get my finger in. All right, I should feel a rush of air. In this case, the patient had a significant pneumothorax, so you got a rush of air and some blood that came out. I make the hole big enough to get my finger in, sweep around, make sure there's no adhesions to the lung. At this point, I'm going to ask for the tube, which I would have prepared beforehand with the hemostat on. I like to put the hemostat underneath, basically coming into the hole that I've made, and then angle it cephalad, take the hemostat off, and advance the tube until the last hole is inside the chest. At this point, you're going to get a big rush of blood. If you want, you can have a clamp on the end to prevent your feet from getting wet. And the thoravac, or the pleurovac, or the thoraclex, whichever you have at this point, will be attached and placed to -20 centimeters of suction. And I'll place an occlusive dressing over this after I suture it in place, typically with a nylon suture to hold the tube in place, and place this to minus 20 suction.